aspiring PharmD professionals. It is wonderful to see such an enthusiastic gathering of bright minds from across the country, united by a passion for learning, innovation, and excellence in pharmaceutical sciences. Today, we have two distinguished speakers with us who brings exceptional expertise in oncology and patient care, and their insights will surely broaden our horizon and sharpen our clinical skills. Our first session will be delivered by Dr. M.G. Giriappa Gondar, MBBS, MDRT, DMRT, Head of Department, Radiation Oncology, Karnataka Medical College Research Institute, Hubli, Karnataka. With decades of experience in radiation oncology and cancer care, Dr. Giriappa Godar will guide us through preventing medication errors in oncology and dose modification based on toxicity grades. This topic is crucial for every clinical pharmacist aiming to ensure patient safety and treatment efficacy. Our second session will feature Dr. Srihari R., PharmD, clinical specialist and BMT coordinator at the Regional Advanced Center for Transplantation, Hemato-Lymphoid Oncology, and Marrow Disease. Believers Church Medical College Hospital, Kerala. He will speak on emerging trends in hemato-oncology pharmacotherapy. This session will provide us with valuable updates on cutting-edge treatment approaches and evolving pharmacological strategies in oncology. Let's start today's first session. Dr. M. G. Kiriappa Godar, radiation oncologist, head of department, cancer care specialist. Accomplished radiation oncologist with clinical expertise in diagnosis, treatment, and holistic management of cancer patients. Currently serving as a head of Department of Radiation Oncology at Karnataka Medical College and Research Institute, Hubli. Specializes in head and neck gynecological and breast cancers with advanced proficiency in brachytherapy. He has successfully treated over 10,000 patients and contributed to global oncology knowledge through international publication. Sir is an MD in radiation oncology from Christian Medical College, Vellore, Tamil Nadu. MBBS from JJM Medical College, Devangiri, Karnataka. He is the head of Department Radiation Oncology, Karnataka Medical College and Research Institute, Hubli, Karnataka. He is a lead multidisciplinary oncology team providing state-of-art radiation therapy. Expertise in high precision brachytherapy techniques for gynecological and other cancers. Developed treatment protocols that have improved patient outcomes and reduced complications. He has delivered care to more than 10,000 cancer patients, focusing on evidence based medicine and patient centered care. His area of expertise are head and neck cancer management, gynecological cancer, breast cancer treatment, brachytherapy, multidisciplinary cancer care coordination, clinical research, and academic monitoring. He is an author of three peer reviewed research papers published in international journals on advanced radiation oncological practices. He is a founder of tumorboard.care, an innovative online platform that provides expert second opinions on cancer treatments, connecting patients and caregivers with oncology specialists to ensure the best possible treatment decision. So, without further delay, let us begin today's learning journey. Please join me in warmly welcoming our first speaker of this evening, Dr. M. G. Giriappa Godar. Welcome, sir. The stage is all yours.
First of all, I thank organizers and Madhu for giving me this opportunity. Hope I am audible to all of you.
Yes, sir, you're audible.
Okay. So when we had joined MBBS, pharmacology was a very tough subject for us. Passing was really tough, but you guys are studying it for a very long period of time, which is really a wonderful opportunity for you to know everything about pharmacology. It's really amazing subject. And even in our college, the PharmD students are posted for a short internship posting. So we have come across few situations. So I would like to share my experience about pharmacology, especially in the field of oncology. Thanks for the introduction. Is my slide visible to you?
No, sir.
Now, can you see my slide?
No, sir, it is not visible. We can see it now, sir.
Now, is it okay? Oh, yeah. Okay. So my topic for today is preventing medication errors in oncology, dose modifications based on the toxicity grades. So this errors in oncology is very, very common, and it's very important topic. And definitely the dose modification system we follow in different clinical scenarios. We'll discuss about it later. So what are the medication errors? As per the definition of National Coordinating Council for Medication Error Reporting and Prevention, any preventable event that may cause or lead to inappropriate medication use or patient harm. So that is called as error. So error is different from the complications. Complications are bound to happen, but errors can be avoided. For example, hair loss from the chemotherapy, definitely it is not possible to prevent it, but errors definitely we can avoid. So what are the examples where in oncology we can have errors? For example, we may prescribe wrong dose, wrong drug. We may prescribe wrong route to the patient, or we can give wrong to the wrong patient. So these are all the clinical situations where we can come across errors in the oncology. So why oncology is high risk? Can you see now? Slide, it is bigger. Slide is visible.
Yes, sir, it is visible.
Okay. So oncology is something which is very important area where we have very therapeutic, in a narrow therapeutic index. If you give a less dose, probably the outcomes are very poor. And if you overdose the patient, and probably risks of having complications are very high. And regimens are very complex. For example, FOLFOX, FOLFIRINOX, the dose, PSA calculations. These are all very, very complex. And once drug goes into the body, and probably patients might have severe complications or consequences. And the oncology practice is a teamwork. So it starts from prescription of the medications to mixing to administration by the staff nurses. So it is a totally teamwork. And incidences of errors happen both globally and India. Especially in India, we have a lot of chances for errors that will happen because we don't have a comprehensive cancer centers in all the cities. These errors can lead to morbidity and mortality for the patient. So what are different types of errors? Errors, I was telling you, it can happen during the prescription of the medication and at the time of dispensing. A pharmacist can dispense a wrong medicine. For example, vincristine, vinblastine, looks same thing. When especially when a doctor prescribes medicines with his handwriting, it's very difficult to understand sometimes. And error can also happen at the time of administration of the medications, which I'll show you some examples. And monitoring also is very important from the starting of mixing to the administration to completion of the chemotherapy. Even after the completion of chemotherapy, errors can happen. And if you don't prescribe proper medications to prevent nausea, vomiting, or to prevent immunosuppression, you have to prescribe sometimes growth factors. If you don't do this, probably patients will have complications. So I tell you about one or two incidents which have happened in my personal clinical practice. So there was one patient by name, 56-year-old lady who was diagnosed with ovarian cancer. She was diagnosed in stage 4. She was planned for 6 cycles of palliative chemotherapy with paclitaxel and carboplatin. So she took 2 cycles of chemotherapy, and third cycle she was admitted. She completed paclitaxel and carboplatin was started by a staff nurse. And after some time, patient must be sleeping, and this IV line was disconnected from the patient. Whole of the chemotherapy fell down on the floor. And after seeing this, sister uh, bought another dose of carboplatin of 450 mg. She reconnected. And when we came to know about this incident, she did not even report to us. So now the question is how much dose in the previous carboplatin dose which has entered the body, which we do not know. So this again 450 mg entered the uh, patient. So these are some of the errors where it is difficult to identify the the reasons for consequences. So here the IV cannula was and even the IV line was unnoticed, and there was inadequate monitoring. There was no alarm system, and the staff nurse did not disclose the incident to the doctors. And she again bought one more medicine from the pharmacy, and that again the pharmacy also did not inform us. So these are some of the errors which are actually preventable. Okay. So what are the contributing factors for this error? Staff are not trained in oncology, especially when we are infusing chemotherapy in the general hospital, if not oncology trained hospital. And most of the time, our staff nurses will have very high workload. And we don't have a real time monitoring of the chemotherapy medication infusions. And fear of blame leads to concealment. So they may think that doctors will scold, hence they try to hide the incident. So how to solve these things? We should ensure infusion pumps are always in functional alarm mode. Whenever there is a problem, it will give alarm so that we'll be able to monitor it. And reinforce frequent visual checks. So when we start chemotherapy, so we have to see it every half an hour, 1 hour. And we should establish in the hospital error reporting policies to increase the transparency rather than scolding the staff. So another patient who was known to me, who was diagnosed with a stage 3 breast cancer. She was 80-year-old. She undergoes surgery for breast cancer known as mastectomy. And after that, surgeon gives 6 cycles of adriamycin cyclophosphamide chemotherapy. She already had a hypertension. So she comes to radiotherapy department for radiation and found to have breathlessness, fatigue, and not able to walk a very short distance. And when we observed this, we thought that it must be because of the adriamycin. So we did 2D echo scan, and the left ventricular ejection fraction was 30%. The echo scan, which was done just 4 months back before surgery, was ejection fraction was 58%. So we did not give her radiotherapy because she had a very severe breathlessness. So adriamycin is a medicine which is cardiotoxic. So especially when we are using it for elderly people, we have to be very careful. And generally, we don't use 6 cycles nowadays universally. So we generally use 4 cycles, especially patient is elderly, we don't use adriamycin. We should also look at comorbid conditions like hypertension, diabetes, or if the patient is already having a existing heart disease, which will actually increase the risk of these toxicities. So infrequent cardiac monitoring. Suppose you still want to give adriamycin, but we should have measured her cardiac functioning by doing a ECG or serial echograms, which were not done. So when we give adriamycin, there is a ceiling. If it is given more than 300 to 400 milligram per meter square of cumulative dose, it will lead to cardiac toxicity. Heart failure rates are up to 20% when we infuse more than 500 milligram per meter square. Especially when we are giving it to elderly, they may show higher toxicity than the younger patients. So we should always look at, when we are giving adrenaline, we should always look at patients' symptoms like breathlessness, fatigue, ankle swelling, post chemotherapy. And if there is a rapid drop in the left ventricular ejection fractions by doing 2D echo, so it should give us some alarming alarm on the cardiotoxic effect. So again, here we should have done a serial echocardiogram. We should have considered non-cardiotoxic regimens like paclitaxel, or this patient should have been treated with just a hormonal therapy. So though it is indicated, but this error could have been prevented. So patient education is also very, very important. So they should report us their symptoms early to the treating doctor or to the treating team. So another incident, generally cisplatin is the most commonly used medicine in the oncology. So it is highly toxic, it is nephrotoxic, it is ototoxic. It can cause a lot of toxicity to the human body. Cisplatin is most commonly used during the radiation as a concurrent chemotherapy as a radiation sensitizer. So generally we do audiogram, understand their sensory neural hearing status before we infuse the cisplatin. So another added risk factors are like, advanced age. Patient is having already maybe having hearing defect. Cumulative dose. If you are giving 6 cycles of chemotherapy, we should assess the cumulative dose. If kidney functioning is not good, more dose will be there in the body and it can lead to more damages. Concurrent use of another ototoxic medications or diuretics can lead to more damage to the patient. This should have been avoided. So this incident happened. One of my patient came to me for radiation for head and neck cancer. He received 6 cycles of chemotherapy with cisplatin. Before starting radiation and chemotherapy, he was perfectly all right. He was able to talk to me without any hearing problem. After receiving 6 cycles of chemotherapy, his hearing went down. So this hearing loss because of the chemotherapy definitely would have been prevented. So once established, this cisplatin-induced hearing loss is usually permanent. So these are the very common errors that can be seen in the oncology practice. So there are other types of errors which can also lead to different outcomes. For example, calculating body surface area. We generally give chemotherapies, calculate the dose based on the body surface area. Suppose if the patient is obese, body surface area can be different from the general average person. If the patient is very thin, we may underdose. If the patient is very obese, we may overdose. It can lead to both overdosing and underdosing. Underdosing reduces cancer cure rates. It has been seen that up to 20% of relative reduction in the survival for women with breast cancer and up to 9 to 10% of reduction in the cure rates have been seen in the advanced testicular cancers. And myelosuppression as a dosing check. Lack of expected myelosuppression. For example, post-chemotherapy, if the patient is not developing any myelosuppression, we may see that, we are giving underdosing. We should check that. So there is one more situation where dose rounding is safer and more cost effective. For example, if the patient, after calculation of the dose, it comes around 1 or 2 mg. So usually strength will come in 100 mg, 50 mg, 20 mg like that. So you should round off to the nearest number. Like, if it is 105, you can round off to the 100 mg. This will reduce compounding errors, cost, and complexity. Okay. So practical rules for chemotherapy dose calculations. These include checking drug elimination pathways. You should always see, as a pharmacist or as a pharmacy student, you should know pathways of each and every medications. You should also know the drug interactions, what medications will reduce the efficacy of the drug. And also we should adjust the dose based on the organ function. And we should also monitor biological endpoints. For example, what is the absolute neutrophil counts after giving chemotherapy? What is the platelet counts? We should look at these things also. Always having dose calculations, we should double check and give the dose before infusing the medications. Okay, you understood? These are the situations where we see errors. And also, if IV cannula is not there in the vein, that can lead to extravasation. This is also, though it is a complication, definitely it can be avoided. We can also consider this as a error. So once, if you feel that there is a swelling at the site of infusion, immediately the chemotherapy has to be stopped. So looking at the other aspect of toxicities, toxicities are broadly classified as hematological and non-hematological. Hematological toxicities are very, very common. We see them post chemotherapy for most of our patients. So we make dose modification based on the toxicities, based on the grades. We generally follow CTCAE toxicity grading. This is known as common terminology criteria for adverse events. So toxicity grades are classified as mild, moderate, severe, life-threatening, and death. And these grades will help us in modifying the decisions of the dose. So general principles on dose modification. So based on the grades of toxicity, either we have to consider continuing chemography with the same amount of dose, same frequency, or we can delay for some time to recover from these toxicities, or you can reduce the dose, or you can discontinue the chemotherapy schedule, or you can change over to the another type of chemotherapy. So consider also you should consider organ function, whether particular organ is affected. For example, bleomycin causes lung toxicity. So if lung toxicity is very high, you should reduce the dose or you should stop giving bleomycin. Also look at comorbidities, patient status. Sometimes patients will lose a lot of energy post chemotherapy. Also, you should look at these things. So hematological class toxicities are especially patients will have all lines of immunosuppression like neutropenia, thrombocytopenia, and hemoglobin also will come down. So neutropenia are classified as grade 1, 2 with the absolute neutrophil counts of more than 1,000 per cubic millimeter. Grade 3 is 500 to 1,000. Grade 4 is less than 500 ANC per cubic millimeter. So if in generally with the grade 1 and 2 reactions, we will continue with the same dose and monitor the patient for further reduction in the ANC. If it is grade 3, we can delay next cycle of chemotherapy until recovery for at least 4-5 days or 1 week of time. Or we generally give growth factors colony stimulating factors, and restart with a 20% reduction in the dose of chemotherapy. And we can also do hold until recovery, give GCSF, restart with 25 to 50% dose reduction in the chemotherapy. Thrombocytopenia, again, more than 50,000 platelet, we can continue with the caution. Less than 50,000, delay the chemotherapy. And grade 4, hold the chemotherapy, restart with dose reduction. Okay. And in case of non-hematological toxicities, if it is grade 1 and grade 2, we will continue chemotherapy with the same dose, same frequency, with the supportive care. And if it is grade 3 and grade 4, especially we see these grade 3, grade 4 reactions during radiotherapy. We give chemotherapy along with radiation therapy. We see a lot of mucositis and stomatitis. So we continue chemotherapy if it is grade 1 and grade 2. And if it is in grade 3 and grade 4, we try to skip 1 week chemotherapy. So diarrhea, again, grade 1, 2, continue with loperamide and hydration. Grade 3, grade 4, try to discontinue treatment for some time, give the patient gap so that let the patient recovery, and then we can start the treatment again. Peripheral neuropathy, very common with many drugs, cisplatin, very common with paclitaxel as well. So again, here we will try to reduce the dose if it is high grade of toxicity. Okay, so again, same thing. So this diarrhea is very common with irinotecan and capecitabine. Again, we do treat these patients with hydration and antidiarrheals. If there is hepatic and renal function changes, we will adjust the dose of cisplatin. For example, weekly cisplatin we give, and we try to give, instead of 40 mg per meter square, we will try to give 30 mg per meter square. And same thing with the methotrexate doses. Monitor organ function before each cycle. So there are definitely certain situations wherein you should look at special care, like pediatric patients. You have to double check those elderly patients who may not tolerate the chemotherapies. And if they found to have toxicity with chemotherapy, they definitely discontinue further cycles of chemotherapy. See that they complete all the chemotherapy, scheduled chemotherapies in time. And patients with comorbidities like heart disease, hypertension, diabetes should also can modify the dose. So whether you're giving chemotherapy based on the weight or based on the body surface area, you should also look at that. If the patient is very obese, your BSA calculation might go, BSA might go up, and probably dose will be very high. You can modify the BSA, and there are criteria to modify BSA and start the dose. Okay, so these are some of the situations where you have to look at each and every patient customized to their cycle of chemotherapy. So what are the strategies to prevent errors in the oncology practice? At system level, we have solutions like, you can prescribe medicines with electronic prescribing, so that, the dispensing person will understand the medicine properly. So with the dose, and we should also follow some standard protocols for each different cancers, and double verification policies. You should also check with other colleague or something. At the individual level, so look at personal checklist, whether the patient name is same, drug is same, dose is same, or the expiry dates, etc. We should check these things and then infuse to the patient. And your colleague should, or your senior also should check the medicine and dose. And it's a continuous learning process to avoid the errors. So safe chemotherapy practice, all the anti-cancer medications have potential toxicities. You should use with caution. So verify patient identity regimen, cross-checks dose, route, drug preparation. Select dose based on the patient clinical profile. consider organ function, performance status, comorbidity, as we have already told, adjust for age, weight, and prior therapy. Suppose patient has received a chemotherapy or initially radiotherapy, and probably tolerance of chemotherapy will be lesser. Monitor regularly during the treatment, observe for early signs and symptoms of toxicity, perform relevant lab investigations like CBC, LFT, RFT, lung functions, etc. Also, we should educate patient regarding possible side effects so that the patient will report to us at an initial stage so that we can treat in time. Encourage immediate reporting of concerning symptoms. A modified dose in special situations. So these are the some of the principles that we must follow to avoid errors in our clinical practice. Okay. Thank you.
Thank you, sir. If you guys have any questions, feel free to write them in the chat box.
Hope you have understood the topic. Any questions? Okay. Jai Naeem. How strictly are dose adjustment made according to the toxicity grade versus clinical judgments? Yeah, it is very tricky situations. You should have an experience to make clinical judgment, and we cannot strictly go on the toxicity grades. Sometimes only platelets should have come down and total counts are normal. Sometimes total counts have come down. Patient is not toxic, doesn't have fever. You can go ahead and give the chemotherapy. So these are the situations where you will get experience and you can continue chemotherapy. Okay, how to manage? Anirudh has asked question. How to manage different toxicity grades occurring in cisplatin or adriamycin? Please kindly clarify and do the name. Okay. So basically, different chemotherapy schedules are there for different situations. For example, breast, we don't use cisplatin there. We use adriamycin cyclophosphamide followed by paclitaxel. So each drug will have different toxicity profile. So we should know the toxicity profile. So if you find different toxicity based on the drug you have administered, you can definitely manage that. As I was telling about cisplatin, it is ototoxic, it is nephrotoxic, it can cause sperm damage, it can cause infertility. So you should, if person is not married, does not have kids, you should ask the patient to, ask for a sperm preservation. These are clinical situations you should know before you are infusing the drug. One of our PG in the clinical practice, instead of paclitaxel, sorry, in the AC is the regimen we use in breast cancer, adriamycin and cyclophosphamide. He thought that it is adriamycin and cisplatin. He had written 600 mg of cisplatin. We never use 600 mg of cisplatin. So otherwise, patient should have received this kind of dose. So definitely this would have at a different situation consequences. So depending on the drug and its toxicities we manage. Okay. Is there a standard protocol here for dose modification in chemotherapy or chemoradiation patients? Yes. Definitely you have to adopt your own protocol in your center. So definitely it is between the medical oncologist and radiation oncologist. The benefit of chemotherapy will be like 5 to 8%. And the benefit of radiation will be like more than 95%. So we should not stop radiation. We can actually skip one dose of chemotherapy instead of stopping radiation if patient is having toxicity. So in different situations, we have to adjust based on that. Any other questions? Have you been posted
Sir,
in oncology? Okay. Do you think the biggest barrier to preventing errors is knowledge, workload, or communication gaps? See, there it is a basically it is a teamwork, and I understand that if there is no training for a nursing staff, definitely she would land up in some errors. And the communication gaps also. Say, suppose you are mixing chemotherapy, and there are 5 to 6 patients of similar chemotherapies. For example, AC chemotherapy, each patient will have different dose. High chances of errors can be there in that situation. Of course, these are really big situations. I mean, like lack of knowledge, lack of communication definitely can lead to errors. Are there ongoing quality improvement projects in this area where a PharmD student could contribute? Yes, yes. I wanted to tell you, the PharmD students has got a very important role in avoiding these errors. See, doctor's job is to diagnose the disease, and you should come up to the level of prescribing medications and monitoring treatment, monitoring the side effects, etc. So because you are studying this pharmacology for a very long time, so you should have more knowledge than the doctors. And doctor's job is really to diagnose, prescribe medications, but you are the one who should actually analyze. Definitely, you have got a very important role in the future. Okay, very good question.
is there any more questions? Please feel free to write them in the chat box.
All of you are students, right?
Yes, sir. Most
Okay,
are the students.
most are students. Okay. So generally, when we are studying, we will be studying for certificates most of the time. So we don't try to see the clinical situations. Only if you spend in the time in the hospital with the different clinical scenarios, you will come across many problems like this. So then you will gain the knowledge. Okay, thank you.
Thank you so much, sir. I think that's all the questions. Thank you so much, sir, for these amazing sessions. I'm sure all the participants learned a lot from this. Let's give a huge round of applause for the sir.
Sorry.
I was saying thank you, sir, for this session.
Thank
I'm
you. Thank you so
sure
much. Yeah.
students learned a lot.